How we all doing? Still awake, still vertical, so we can't complain too much, right? So, welcome back. Hope you had a good night last night. I know it's 1 hour earlier than we'd like it, but it's the powers that be. Just won't let us stay on one time zone. So there we go. And it's a Sunday to boot, so we're all good. All right. So yeah. So on that note, we're going to talk about another pleasant topic. So I left you with pediatric cardiac arrest yesterday, which was like, oh my god. So now we're going to talk about, well, what happens? Bad things happen after someone gives birth. It's like, does it get any better? Lord. Uh, but these are things that not really so much that they're going to be extremely life-threatening. There are a couple things that we'll talk about that could be, but a lot of this comes down to uh, really a really rare event because most of your out-of-hospital births, most of them, are going to be relatively simple. Okay, it's a push, it's a catch, don't drop, right? Warm, give it back to mom, put your stork on the bus, go back to work, right? And it's the way it goes. However, because of the birthing process and things that do happen with mom during that gestational period, there's changes in the uterus, changes in her body chemistry, things that go on like that. There can be some consequences after the babies are born. And that's another thing to think about as well, is that when you get there, and it's the first thing I always make sure I check and ask the parents, is like, how many do you have on board? Because it looks like only one, but there might be like 2 or 3 in there. And that can cause complications as well. We're not going to talk about that a whole lot in this lecture, but we'll talk about some of the consequences of having multiples that are going to sometimes precipitate, more likely, some of these things we're going to talk about. All right. So when we look at what this actually is, this is broken down into kind of small little chunks as far as time goes. But the first time that we look at here is usually up to about 6 weeks after giving birth. And what's going on is that, well, she's been kind of transformed for the last 9-ish months. And now she's trying to reverse everything slowly and trying to get back to normal before the point where she had gotten pregnant in the first place. Unfortunately, during this time frame is where they're also most vulnerable because of those dynamic changes that occur. That can put a lot of stress that mom's not used to. And because of the changes in her anatomy and physiology that's happened during the gestational period, some of these changes can be somewhat abrupt, or at least appear to be abrupt. And literally, it's like hitting a brick wall, and bad things start to happen. So this is where we tend to catch most of these patients, is in this time frame here, which is about a month and a half, give or take, after the patient's already given birth. So during that time, we kind of break this down, like I say, into different little spots. So up to the first week or so, you get what's called the initial, or what's known as the acute period. And right here, about day 3, is where there tends to be, now, if stuff starts to manifest, this is where we're going to see it. And we've all had those patients or heard about those patients that had some degree of postpartum depression or something similar to it, right? Well, this is typically when it tends to kick in because, like I talked about, when those hormone levels are changing, this is where that peak tends to be. And that's when, obviously, all the emotions start to become a little bit more skewed, so to speak. And it can go a little bit longer, but it's that change in those estrogen levels going from very high levels during the pregnancy, all of a sudden just bottoming out. Right? Like I said, it's like hitting a brick wall. It has kind of a hard effect on some of these females after they've given birth. That in and of itself can cause problems because obviously if they become mentally distraught and do things that sometimes happen, I mean, we can be called for those types of problems. But you also see the list here of other possible types of changes that can occur during this time frame. We're going to talk about some of these in a little more detail here. But the fact that the uterus now is outside the body versus inside the body, last time I heard that's not a good thing. And that can happen very easily simply from the birth process, but this is also part of the reason why we've always been told to be careful about when we're assisting with the birth, not to pull too much on the cord or anything like that, because it can precipitate this as well. They could also suffer from what almost looks like an anaphylactic reaction. It's what's called an amniotic fluid embolism. We're going to talk about that in a little more detail as well. And what it comes down to is that there is what they think it is that it's possibly a mixture of amniotic fluid and the contents, like, you know, the hairs and all that other stuff the baby had while it was growing, gets mixed in during the birth process into the bloodstream of mom and then sets off that reaction. Preeclampsia and eclampsia. Everybody thinks, well, that's just happening while they're still pregnant. And it is, but it can happen a number of weeks after the birth process as well. So you get called for a seizure and she's, you know, 7 days postpartum. That very well still could be an eclamptic type of seizure that you're dealing with. Okay? Could be something else, but it could be that. And then, of course, the bleeding. Now, there is some amount of bleeding that's always expected. We're going to talk about the different stages of that here in just a minute as well. But out and above that is where we have to have our concern. All right, the next part here, this is the bleeding that I kind of mentioned a little bit, is what's called a lochia. And it typically, like you can see here, will last for even upwards of about a month. But as the uterus starts to get back to its normal shape, as that tissue starts to regenerate and re-heal, the color and the flow starts to change as well. So initially in those first couple of days, it's going to be a nice heavy flow, kind of darker red, maybe some clots in there, and that's still that uterine inner lining tissue that's just coming off. After that, you look at the next week or so, then it turns a little bit darker pink. The consistency gets a little bit thinner because now it's kind of like that, they call it the serosa, and it's kind of like what you have for interstitial fluid. Kind of that same consistency is really what you're seeing there. And then finally, like I said, up to about a month, you have now kind of a lighter, almost yellowish type, and then eventually it stops altogether. Now that's the normal flow, but sometimes these can be delayed or can be prolonged depending on what happened during the birth process, right? All right, so that's the first week-ish. After that, we get what's called the subacute period. Now what you have, in this case here, is, again, lots of different changes, and now the rest of the anatomy and the physiology is kind of getting back to normal, what it was. The diaphragm now is able to kind of open itself up because the uterus has been compressed. All the organs in the abdomen that were kind of squished everywhere from the center, well, they're starting to come back where they're supposed to go now. And again, blood pressures are starting to change, heart rates are changing, and all that kind of stuff as well. But you also have these other itises, so to speak, that start to continue, I should say, for the most part. And on top of that, what could be noticed is something we're going to talk about towards the end here, is that due to the pregnancy and, of course, the increased fluid amount that she's always circulating, she may have developed a cardiomyopathy, an enlarged heart, secondary to the pregnancy. And it's something quite serious. Now, the thing is that it's quite rare as well. Now, I say that with an asterisk because I did this lecture a number of years back, first time in Virginia. And I made that comment. And sure enough, I got done with the lecture and 5 ladies come up to me out of the crowd. Every single one of them had this. And it was like, wow, you know. And fortunately, most of them had a pretty good story to tell as far as how they recovered. One had some, you know, pretty serious complications, but she was still okay. So like I said, we'll discuss that a little bit more in a little bit. Up to now, we have what's called the delayed postpartum period. So this can be in upwards of 6 months in this case. And now we're basically, again, back to hopefully normal. Okay? Normal uterine size for the most part. The connective tissue and everything else is back and kind of back to its tensile strength that it used to have before the pregnancy. And again, this is a very slow acting process, and typically around here we don't see a whole lot of problems, but they still can happen. So in that 6-month postpartum period, we still have to be aware that if we're dealing with someone that had recently given birth, is that related to the pregnancy? And again, up to a half a year, some of those things that we're going to talk about could still possibly be the culprits. All right, so let's start with the easy stuff first. And we're going to go over bleeding. Now, as I said, the bleeding in and of itself is expected. But after a certain amount, now it becomes abnormal. And that's where we get a little more concerned, and probably what we'll get called, because if anything else, if it continues, you're having volume loss, can lead in some cases to a hypovolemic state and, hypovolemic shock. But after delivery, how many have delivered a baby in the field? Anybody? Okay. So after that birth, I mean, you're still having some bleeding just from it's a traumatic event. And you're going to have some tearing that goes on, hopefully not too much, but it's expected to be about half a liter, give or take. Now, if the birth had been by C-section, you're still going to get some oozing around the site of the incision, but also you're still going to have some loss through the vaginal canal. And because of that trauma to the uterus directly, right, that tissue is still healing up. Again, a liter is still considered to be okay, but a liter is a liter, and that's about 1/5 of our volume. And some people can be a little bit, sensitive to that, and so they may call and have signs or symptoms related to it. Even though it's a normal amount, they could still be symptomatic. But anything above and beyond this is where now everybody starts getting a little concerned. So what leads to this are what are called the 4 T's, so to speak, and that's tone, trauma, tissue, and thrombin. These all have to do with the various things that you see here. The biggest ones you can see as far as percentage is the uterus itself. It will not shrink or will not compress on itself. And this is where sometimes, again, in your textbooks or your protocols, you are told to do what to facilitate this. Yeah, do the fundal massage, right? How many of you ever tried that on a female that just gave birth? Okay, how'd that go? Yeah, stay out of swinging range, right? Because that hurts. What you're trying to do is literally irritate that myometrium, okay, that muscle of the uterus, and get it to basically get so irritated that it's going to kind of seize up, if you will, but it will contract. By contracting, right, it starts to cut off a little bit of that blood flow that's leaking out, but it also helps with the process of healing as well. Lots of reasons why this happens. We're going to talk about a few of them here in a minute. The next thing being trauma. Okay, in this case, whether blunt or penetrating, doesn't make any difference. It's typically blunt trauma. And this could be anything from them getting kicked or punched or falling on their belly to obvious, penetration injuries that, you just kind of let your mind wander with that. Tissue, right? This is another thing. So how many of you that have had those field deliveries, did the placenta actually deliver in the field? Okay, a couple of you. What'd you do with it? Okay, let me ask you this. What color was that bag? Okay, so it's the right thing to do, obviously. But I'm going to tell you a story real quick that you got to be careful about. Okay, had a colleague of mine, same thing. Had a field delivery, actually delivered twins, and delivered both placenta, or placentae, I guess it would be, prior to getting to the hospital. Put it in a red bag, just like we always would. Put it between the patient's legs, thinking, well, okay, here it is. They wouldn't mistake it for something else. She goes out. She's gone for 2 minutes. She comes back. She's talking to the patient. Red bag's gone. She says to the patient, did someone come in and take that bag? Oh, yeah, one of those nurses came in and said they were going to take it and get rid of it. And I'm like, and it wasn't labeled, had no idea what it was, and some tech came in, took it, and tossed it down the fire chute. So my caveat with that would say, if you're going to put it in that bag, which is fine, we should, make sure you take a piece of big tape or something and just label it as, placenta, so that nobody goes and tosses away. But here's the thing, why do we bring it with us in the first place other than the fact that we can? Yeah, they're going to look at it and make sure that all the pieces are there, but also to check if there aren't, okay, do we have to worry about the third T here? Does she have any retained placental tissue? Plus they can use it for other things as well. And the last thing is, does this patient have or developed during the pregnancy any kind of coagulopathy, okay, problems with clotting? And perhaps that's the case. And this can, again, be a relatively rare incident, but it's one of those things that if it is the possibility, there's not much we can do about it. Yes, ma'am. That's a way to do it. Yeah. Yeah. Right. And it's like, well, I don't like this one. Let's try another gun. Yeah. But yeah, just for the people that are on virtually, she mentioned that the cord was actually still attached to the baby when it was delivered, and so it was baby, cord, and placenta. So obviously there was no way it was going to get lost. But they bagged up the placenta and obviously, delivered the child with it still attached. So, okay. So let's look at again that atonic uterus. So unless your name is either last name is Suleiman or Duggar in this case, the uterus usually is not going to be much of a problem, but this tends to be the biggest problem that we see as far as bleeding control. And whether it's that, if she's had problems with bleeding in the past, that can also be something that you can predict that, okay, if it happened before, more than likely it's going to happen again. If for some reason maybe she was preeclamptic and she was being treated for that, and or she became eclamptic and the medics administered mag sulfate. Mag sulfate is a smooth muscle relaxant. And that very well, if it's still in there and still circulating, and especially if they have to give as much as they do, which is grams of it, I mean, it's a lot. That residual effect could still be there, which could lead to that uterus not being able to contract because the mag sulfate is just not going to let it do it right away. Right? And then again, we always talk about the high risk, and that's usually any female over 35, just because of the development, and obviously it's going to take slower, just more time for it to kind of retract. That can also be a precipitating factor for that bleeding in this case here. Now, as far as trauma goes, as I talked about, it can be direct trauma to the uterus itself, blunt or penetrating. But what you can also have, and sometimes it's going to happen whether you make all the precautions or not, is that you can have a perineal tear like you see here. And there's varying grades of it, but it's no matter what grade you put it into, it's only one thing, and it's painful, right? And that pain, and because of the vascularity of this area, it will bleed like nobody's business. Okay, it's crazy. So this is the rationale of why you're always told to try and hold the baby's head as it's crowning to prevent what we call an explosive delivery. Now, if the baby happens to be 10 pounds because it's, he's been in there and eaten all kinds of sugar for the last 9 months, he comes out big, sometimes that tear is going to be inevitable even if you do take the precautions. But we try to minimize them as best as possible. And if that does happen, like I said, you're going to have a large amount of bleeding going on here and a large amount of pain. Your bleeding, no matter what, is always still controlled externally. Right? Put pressure on the outside. It may take a number of pads in some cases to at least get this under control. So we have to be careful about that. And the other thing is, obviously, if she's in a lot of pain, her sympathetic system gets revved up, her heart rate goes up, her blood pressure goes up. So what does that do to the bleeding? Okay, it just bleeds even more, right? So you have to kind of also go back to mom as much as possible and try to use some calming measures as much as you can. All right. The other problem is, looking at trauma, is that what if that uterus does invert? Right? And maybe it's going to happen and there's no way to predict it, it just does. When it does, either partially or totally, one, you're going to have the bleeding. Two, obviously, like I said, it's on the outside and it should be on the inside. But three is, depending on how far down it goes, as far as down the vaginal canal, right behind that is the rectum. That's what you're seeing here. And the problem that you might run across is that now you have this muscle right here that's tied into 3 nerves of the parasympathetic system. Okay? Sacrum 2, 3, and 4. And those nerves kind of bundle themselves up. So you'd have the 3 separate ones, and they bundle up into one separate one. And then it basically goes up into your brainstem, and that's part of the vagus nerve, part of the vagus system. How many of you have been on a scene with your medics that had a person that was in SVT or something like that, and the first thing they told them to do was bear down like you're going to have a bowel movement, right? Or at least you've heard that, right? So you got to be careful because sometimes they do, right? But what they're trying to do is that when you bear down like that, you're putting pressure on, or you're activating that muscle, and you're putting pressure on those nerves, which activates those nerves. Those nerves, when they get activated, release a chemical called acetylcholine. which in a high enough concentration gets into the bloodstream. Now it goes back to the heart and basically slows the heart down. That's the method behind that. So that's that vagal maneuver that you hear about. Here, a vagal response can be initiated because now you've got this big blob through the uterus pressing up against that muscle because, again, it's posterior to it, and inadvertently sets off that signal. And now your patient that has an inverted uterus is not tachycardic, she's now bradycardic, and maybe also altered with her mental status because her perfusion is also affected. So you may have that going on. So if that's the case, you may be directed, and I say may with a very high grain of salt, okay, underlined, italicized, bold typed, may be directed by medical control to try and move that uterus back in. Right? That would be by medical control only. Even at the medic level, we are told that that can happen. I'm still not going to do it without somebody on the other line telling me how to do it. Because I know where it came from, but I don't know where it's supposed to go back. Okay. Now, the other problem is that you get the uterine rupture. And this can happen during birth, just from a very strenuous birth process. If she's had C-sections in the past, she's going to be more prone to it because, well, there's going to be scar tissue there. And scar tissue is weaker than the normal tissue. So like I said, even during the normal birth process, she may just be, pushing, contracting, and it tears. Which now, again, the bleeding is probably going to be contained internally. And so with that, you're not going to see any evidence of it. And in fact, you probably won't see a whole lot of bleeding. You may see some bleeding coming out the vaginal opening, but not a whole lot compared to what they're losing inside that uterus. The uterus, at its full gestation, can hold an upwards of about 5 to 6 liters of volume just by itself, which means what? They can literally almost bleed out into their belly and you won't see any change. What you're going to see are signs and symptoms of shock, right? And one thing that you can kind of use, which I had to put up here, but I didn't, but I'll just tell you what it is. How many of you have ever heard of the what's called the shock index? A few of you? Okay. It's very simple. Right? What you do is you take the patient's heart rate. At that very moment, you take the patient's heart rate, you divide it by the systolic pressure. And if that number is greater than 0.7, that ratio, that tells you that they have some type of volume deficit. Okay? So heart rate divided by systolic blood pressure. All right, so that's your blood loss. Now, as far as tissue goes, yes, obviously, again, the retained placenta is always a concern. So we want to make sure, like I say, that we bring the placenta with us if we do deliver it in the field. And what also is going to be a problem is that we're not going to know. I mean, their OB might know this. They may not know it either. But depending on how the placenta actually attaches itself to the uterus, okay, depth-wise, can also lead to retained tissue simply because it's going to be deeper with some of these than others. And so there's different names of it. It's called accretia, incretia, and percretia. The biggest thing in here is that this last one, this is our biggest problem. Because as you see right here, on the very right-hand side, the uterus has pretty much invaded the whole lining of the, the placenta has invaded the whole lining of the uterus and actually maybe outside of the uterus. It's just how it develops, right? When the baby's born, you might get some detachment, but a vast majority of it with that and even the incretia, a little bit even with the accretia here, you're going to have retained pieces. Right? So that's another reason why you bring it with you. Yeah, it delivers, but there may be, depending on one of these three scenarios here, a lot that's left over that you just can't deliver because it's still, the uterus just isn't going to detach from it, which then prolongs the bleeding as well, obviously. In some cases, they may have to pull the uterus, yeah. With a lot of times with the percretia, that unfortunately ends up being the case simply because there's just no way to repair it. Those do a hysterectomy, yeah. Depending on the other two, how much the invasion is, sometimes they can do the D&C enough that they can get it out, but it's, again, it's just a case-by-case basis. Unfortunately, with any one of those three, the likelihood that they're going to have a hysterectomy is much higher than not. Obviously, if it's a younger patient, they try to avoid that. But there are some instances where, like I say, we go back to the high-risk obese, your females over 35, they may say, you know what, I'm one and done. and they're okay with it, and they pull it. The other problem is that if it is still retained, then it also sets them up for longer term complications as far as bleeding, obviously, but also infections. Okay? Endometriitis, endometriosis become very common with these patients postpartum down the road, which you may be called for as well. All right. The other things that we worry about the placenta, or we talk about a placental, it's Sunday, sorry, abruption. It's over here on the left. So what can happen in those cases is that you get this tearing of part of the placenta prior to birth, which again can be due to trauma. This can be due to a patient who's developed preeclampsia and they're hypertensive. If they have clotting disorders and tissue disorders that have issues with connective tissue, that can be a problem. But it can separate partially like you see here, or sometimes completely, but in most cases, the bleeding that's going on is concealed because of how it tears. So it still bleeds inside the uterus and it pockets in one of those three areas like you see there. We don't see much on the outside at all. Okay? It's usually very dark and very little amount of blood, but it's also very painful because you're literally tearing. Just think about taking a hunk of your skin, trying to rip it off your arm. That's gonna hurt. That's literally what's going on here. So they will complain of that extreme amount of pain. They may also have that altered shock index. Okay? You'll take their heart rate and divide it by their blood pressure, and you're going to get that ratio above 0.7. But the uterus may change. You palpate it, you might find a hot spot, you may not. Right? Sometimes it gets concealed very well. Now on the right-hand side here is what happens with what we call placenta previa, where now basically it's attached correctly, unlike what you saw back here. So we're still in this normal attachment mode, so to speak, but where it attaches is the problem. And it's not in that upper third where we would like it. It's down lower, partially or sometimes totally covering the cervical opening. So what happens at this point is that once the cervix starts to dilate in that first stage of labor, it really doesn't have a whole lot of nerve endings in it, right? So it's kind of like a boggy little mass. So when it tears very easily. It's like tissue paper almost. So when that cervix starts to dilate, it will stretch that placenta, and when it tears, well, as you can see, especially with a complete or partial here, the vaginal opening's right there. So they will bleed crazy amounts of blood, bright red blood, but they won't feel any pain. It's like they'll wake up and the bed's just soaked. Like, where'd that come from? Or they go to the bathroom and all of a sudden look down and it's like something out of Cujo and there's just blood everywhere. But they didn't feel anything, but the bleeding is tremendous because now it's the placenta that's actually leaking straight from the source. Unlike with an abruption, it's retained. So like I said, whatever blood you do get, it's usually taking a longer time to get down there. So it's kind of coagulated, deoxygenated, so it's darker, but the pain is there because of that ripping from the uterine lining. So that's the difference between those two. Still leading to bleeding, obviously. All right, and then the last thing, which is the rarest of the four possibilities, is issues with clotting. And again, you can see the various risk factors here that can lead to this. One, like I said, this amniotic fluid embolism, we're going to talk about that here in just a minute. But the abruption, your patient who's preeclamptic, your septic patient. Sepsis and all the other infectious diseases that are combated on a daily basis, well, they tax the immune system. And when the immune system, if she's truly septic by definition, her immune system's kind of gone into hyperdrive. And the result of all of those parts of the immune system doing their job correctly releases a lot of chemicals. And one of those chemicals actually causes platelet count to drop. Reason being is because if you're septic, it's a distributive type of shock. So your blood vessels everywhere are dilating. And what happens is, especially at your capillaries that normally have this little window between them that's about, yay big. Well, now when you dilate the capillaries, what happens to the window? It gets bigger. So consequently, you have basically Swiss cheese kind of consistency in your blood vessels that are just full of holes. So the bloodstream and its platelets try to keep plugging holes, right? Left and right. Well, the problem is eventually there's too many holes and not enough platelets. And if that happens and the platelets aren't there and she gives birth during this time or subsequently afterwards, what's going to happen is that she's going to prolong her bleeding because the things that are supposed to stop the bleeding, they just aren't there anymore because they've been used up and she can't replace them fast enough. Now, the other possibility is, and this is kind of the rarest of the possibilities, is that she may have a deficiency in what's called von Willebrand factor. And basically what this does is that this is what allows, among other things, to help platelets stick together. And it helps contribute to clots and obviously stopping that loss of volume out of the pipes. So if they have this, they've already been diagnosed with it well before their pregnancy, and they should know this. This can lead to them being somewhat classified as a hemophiliac. Now, that being said, this website that you see down here at the bottom, and you guys will have access to this afterwards too, so you can have all this information. I'll show you when we're done here. After the birth occurs, those factor levels drop even more. So now she's even more prone to bleeding. And as I said, what you may need to do is contact directly a hemophilia center that can help you basically get to the right facility for this person. And that's where that website goes to. You can plug that in and it will basically GPS to your location and will tell you the closest one to your vicinity. So sometimes this might, again, change your transport decision as far as, you know what, we just need to fly this person out of here because if she goes to the local station, she's gonna die, right? All right, so that's bleeding. Otherwise, what are we doing? Normal bleeding control, shock care, you know, keep her warm, keep her oxygenated, stop any external bleeding that you can find, be suspicious of the internal bleeding like we talked about, especially if it's intrauterine. Try to slow that process down. We can try the fundal massage, we can try other things. At the EMT level, that's basically all we've got. At the more advanced levels, what they're gonna try to do, among other things, is administer TXA, if they've got it. The other things that we watch for are, like I said, your shock index. And even that, you look at the mean arterial pressure. Now, most people are like, oh, what's that? How many know where to find the mean arterial pressure on a monitor? Where is it? Yeah, the machine calculates it for you, okay, which is great. So when you have a non-invasive blood pressure cuff, you pump it up and it gives you the, 130/60, whatever it might be. That little number off in the corner, right? That's the mean arterial pressure. And typically what you want to do is you want to try to at least attain or maintain somewhere between 65 and 70 at bare minimum. 70 to 110 is normal. So if your numbers are in that range, even though your systolic or diastolic don't look that good, you're okay for that moment. But it's much more accurate than your blood pressure that you get. So if you have to choose between the two, either one, use that shock index to make your suspicion. And again, heart rate divided by blood pressure, or just look on your monitor and see what that number is. If it's higher than 65, you're okay temporarily. If it starts to dropping, you know that there's obviously more bleeding going on, so you need to kind of step it up and get them somewhere. Either get them to ALS care or get to the hospital, whatever would come first. Like I said, if you had an ALS interceptor, you're working with the medic, this TXA is initially, it was developed for this reason. It was developed for pregnant females that had postpartum bleeding. We all see it today used on trauma patients left and right. Well, it's for the same reason. It's for internal bleeding control. It helps to enhance the clotting effect. That's what its job is. But it's given in this case, typically in 2 increments, 1 gram apiece, about 10 minutes apart. Now, obviously, again, at the EMT level, we can't administer this, but you can do the other parts of the BLS care. Like I said, keep them warm, keep them elevated, keep them oxygenated, and keep them calm, and then control the bleeding. All right, so that's one of the biggest problems that we see postpartum. Another possibility is, and this can happen at any point, this can happen from 2 minutes after birth to 2 to 6 months after birth, just depends. And it's a pulmonary embolism. Bleeding is the #1 cause of maternal death. This is #2. And because of the fact that she was pregnant or is currently pregnant, because they can throw a clot while they're pregnant as well, the changes again in the hormone levels, the blood consistency, and all that stuff that changes with the pregnancy process, the likelihood is that while they're pregnant, they're more likely, as you can see here, to throw a clot perhaps and end up with a pulmonary embolism. But after they've given birth, and when we're kind of trying to reset everything, it makes it even a higher possibility that they could have this. So add again the fact that they've had one in the past, your high risk patient like you see here, and then anything else where they've been on bed rest or even they have a little bit of excessive weight on top of the pregnancy weight that they've obviously had, and or a past C-section because of, again, that tissue that can slough off and the scar tissue that can get into the bloodstream that way. All this can lead to an excessive amount of clot development. And with that occurring, eventually what may happen is a piece of this funky monkey breaks off somewhere, and or you get an excessive amount of clotting in the bloodstream, and now you have what's called an embolus. That's the clot. And it just starts floating around. Eventually, what it does, in some cases, it gets in the lungs and sets up shop. Now, people can have a pulmonary embolism and never be symptomatic because it's just not cutting off enough circulation that causes a problem. The ones that we come across here, either they have multiple clots all at once, or they have one big one that sits somewhere in the midline of their circulation into their lungs, right above the pulmonary trunk. If that occurs, this is basically what's going to happen, right? So you're going to get the chunk here, right? And basically it's going to get in there, and now the right side of your heart has excessive amount of work to try to push past that obstruction. And the right side, as you know, you look at the right side versus the left side of the heart, right side's a wuss. Right? It's got no muscle. It just sits there and pushes. Okay? While the left side's over there going, you need to push harder. I push to the head and the toes and everywhere in between. You puny little man, you just push next door to the lungs. What are you? Right? But by doing that, it doesn't have to have a large muscle because it is just pushing next door. So subsequently, if there's any kind of resistance to circulation in the lungs, that muscle fails very quickly in a lot of cases. The first thing that it's going to do is going to try to enlarge, but by enlarging, like you see in this picture here, it actually enlarges the chamber, and the ventricle gets floppier, it doesn't get stronger. So it fails as a result. And as this cumulative effect that you see in this whole flow chart here occurs, eventually what's going to happen is that this right side, like you see here, is eventually not going to be able to contract at all. Blood's going to get in here, it's going to sit, and eventually it's going to back up in the system. It's not going to go forward. If it doesn't go forward, it doesn't go to the lungs. It doesn't go to the lungs, you don't pick up oxygen. You don't pick up oxygen, well, you know what happens after that. And so if it's in a very, like I say, very large clot or a combination of multiple clots all at once, leads to that dysfunction on that right ventricle, your patient eventually starts getting very symptomatic and doesn't do very well. Now, what you'll start to see also are changes. So what we're doing is we're cutting off, like I said, flow to enough areas that you can't oxygenate. And if they can't oxygenate, even though we're ventilating this patient, you're hearing lung sounds, chest is rising, okay? But your pulse ox doesn't get any higher. It stays at like 90%. Even though you're ventilating with 100%, you got two hands on the mask, you got another person squeezing the bag, the chest is going up, chest going down, you hear lung sounds everywhere. Like, what? The color doesn't get any better, mental status doesn't get any better, because at some point, whatever has been cut off, as far as, you know, this here, you know, alveoli are not getting perfusion by there. It's like being at the bus stop and the bus never shows up. Right? You can sit there all day, but if you got no transportation, I can't leave the lungs. And that's what's happening here. So you get enough mass of that lung that's affected like that, that's when your patient gets symptomatic. And eventually what starts to happen is that you will start to see your CO2 levels also drop, but then again, they're going to hold steady because you're only going to get so much CO2 return, depending on how much airway you have perfusing. But the trend will go like this. You'll start to see it go down and down and down, and eventually then just hover at the level it can. So that's another kind of subtle way you can pick up on the fact that this might be a clot in this case. Other signs and symptoms will probably tip you off as well. But the biggest one is you're oxygenating, you're ventilating the patient, and you don't get past a certain amount. That's not normal. Okay? Pulse ox only gets so high, color only gets so good, mental status only gets so well. And past that, depending on how much of a clot you have, it could be instantaneous, or you may not see it at all. And usually you don't see a whole lot of pulmonary edema with a pulmonary embolism, but if it's big enough and enough of your lungs have been affected, yes, you may get a little bit of that because, again, the capillaries are going to dilate in those areas or try to dilate because the brain's like, hey, I need more oxygen here, so it dilates your capillaries. You get the leakage, you get the pulmonary edema. So depending on how much area of the lung is affected, you may or may not see it, which if you do see it, or if it's there, then that compromises them even more, because if you've got pink frothy sputum coming out of their airway, what's happened? Okay? It's already leaked out of the tissue into the alveoli, and it's in their airway. And it's kind of got, blood products in it. And blood by itself is very caustic. So if it's in the airways, coming up and down, what do you think is going to happen to the airways themselves? They're going to swell, they're going to constrict, and now your oxygenation is going to get even tougher. And now what you might pick up on is it's harder to ventilate that patient. Right? So that would be a kind of a long-term consequence of it, but it can happen, absolutely. Okay, so other than that, again, high flow oxygen by whatever means is necessary. Get them sitting up. CPAP might help in some cases, but again, it's not a ventilation problem, it's a perfusion problem. That's the big issue here, and there's nothing we can do about the clot. Even me at the medic level, I can't give them anything. All I can do is maybe if I have to, I can intubate them, maybe. But I'm just going to make sure they're being oxygenated, ventilated, sitting up, and it's just this, okay? It's just more diesel. This is one of those diesel therapy type patients. You just got to get them out of there because they have to be anticoagulated. You got to bust that clot up. Otherwise, they're just not going to do any better, or clots in some cases. All right, so this is the thing I talked about a little bit earlier. It's a relatively rare phenomenon in someone who is in that postpartum stage. It does happen. Some people would, in the research community would say, well, it's just something that was made up. It doesn't really happen. Kind of like a Trojan horse, right? Well, or a unicorn rather. But what can happen, and sometimes does happen, and how it's happened enough times, they put a name on it, so there's got to be some relevance to it. They give one or two names, either called an amniotic fluid embolism or what's known as anaphylactic syndrome of pregnancy. And like I said earlier, what it basically is that during birth or prior to the birth process, somehow there's a little small deficit in the placenta. And amniotic fluid leaks into the placenta and now starts getting circulated throughout mom's system, okay? And what can happen in that case is because of what's contained in the amniotic fluid, I mean, it's got, well, waste products, it's got nails, it's got hair, it's got, skin, all that stuff that the fetus was basically living in for the last 9 months. Now it starts circulating around throughout mom's normal circulation. And what can happen is that it can cause clotting, so it can lead to a pulmonary embolism, okay, or just respiratory distress in general. What it can also do, though, is set off an immune response that's very similar, almost identical to an anaphylactic reaction. And that's what it looks like and smells like and tastes like when you show up. And it's treated similarly as far as an anaphylactic reaction goes. So if this is something that occurs, like I say, it's going to be one of those things that for the most part, you manage what you find. And there's not much we can do with a lot of these patients, but can be very severe to the point that it can cause demise of the mom, and if the baby's not born yet, can cause obviously death of the fetus as well. All right, so also talked about preeclampsia. And this is the one that everybody kind of shakes their head at, or scratching their head. They're like, wait a minute, this is something that happens during birth or before birth, because it's pre. It's like, well, it has nothing to do. The pre has just, again, it's before they seize. That's all that means. But they can become preeclamptic or become symptomatic anytime, obviously during the fact that they're pregnant, and or up to a certain time afterwards. In fact, in a lot of cases where you see patients become eclamptic, it is after they've already given birth. So that being said, how is it developed? Well, there's your parameters as far as vitals go. So either a systolic above 140 at or 140, and or a diastolic at or above 90 on at least 2 occasions that are measured at least 4 hours apart. Now, this is something that probably their OB, if they've been getting prenatal care, has been watching relatively carefully. Or if they're in a hospital, obviously they're monitoring this 24/7. And if they're a hospital, obviously we're not going to probably deal with them. But if they're outside of the home and they've normally never had any kind of blood pressure issues, and now they're spiking numbers like this, okay, that's part one. The next thing is now they have, at least with this, one other thing that you see on this list associated with it. Okay. Whether it's, again, an altered level of consciousness, some degree of volumes deficit, the headache, which is usually a very common thing, and the visual disturbances, which are another very common thing. Because what's happening here is the hypertension is causing those problems that they're developing. Blurred vision, flashing lights, again, intolerance of light, stuff like that. So a blood pressure issue along with one of those things, at least one, that puts them into that preeclamptic stage. Now, as a result of being diagnosed with this, what are these patients told to do? Or if you find someone who is preeclamptic, where are you most likely going to find them? In bed, right? Because they're told to just basically chill out for the remainder of your pregnancy, because any extra work, any extra stress they put on their system elevates that blood pressure, and then all of a sudden things get crazy. Now, if they manage themselves like they're supposed to, and these numbers can happen, you could be showing up to a patient who has already given birth, you know, again, up to 6 weeks earlier, and they're still spiking these signs and symptoms as well. So that's what you got to keep in mind. The problem is that it's all the placenta's fault, basically. If the placenta wasn't there, we'd have a problem. Of course, if it didn't have placenta, we'd have a bigger problem. But the thing is that they have these things that are called spiral arteries, like you see here. And normally what's supposed to happen is that when the uterus doesn't have the placenta attached to it, you have these arteries that are just normally, like you see over here on this extreme left-hand side. Once the placenta is forming and obviously is attached, and you get the interaction, it's basically like what you see with the astronauts that are going up to the space station, right? The Dragon capsule comes in, has the nose cone, it locks in there, the airlock opens, and off we go, right? We can interact with the crew and so on and so forth. So that's what happens normally, like you see over here in the extreme right-hand side. Those arteries now dilate because of the attachment with the placenta, and you get the normal perfusion that's supposed to be there, okay? And everybody's happy. Now, you imagine that the astronauts would go up there, they attach to the space station like they're supposed to, but no one ever opens the hatch, right? Well, you're going to have a little irritation by that crew that just took, 16 hours to get up there, and it's like, look, man, I got to pee. It's like, let me out of here. And so what happens is that's what you're seeing in this middle picture here, is that you still get the attachment, but now for some reason with these patients that develop preeclampsia, the arteries either partially or don't totally at all dilate. And so now what starts to happen is that now you get a chemical reaction with histamine and other various things that gives off other toxins, and that starts the whole preeclamptic problem, right? So this is kind of how it works. So they start off with it, the arteries don't open up like you see here, and now because the arteries don't open up, the placenta starts getting irritated. It's like I said, like the guys that showed up in the capsule and they don't open the hatch. So now, because of that ischemia, one, they have some fetal issues, obviously, but more importantly, what happens here is that the placenta starts to say, hey, let's do something to open up that hatch. They try to do whatever they can. They're taking hammers, they're taking blow torches, they're taking whatever they can to open that hatch so they can get in the space station. Well, no, doesn't work. But by doing so, it's obviously causing residual damage. And these chemicals that are being released during this process of the placenta trying to open those arteries up, that is what starts to set off the reactions that we see. That's what some of those products constrict the blood vessels. They also cause damage to the liver in some cases. They cause issues with the kidneys in some cases. They cause leakage. And all that leads to that preeclamptic state that we saw with those vital signs, the blood pressures and the changes in vision and so on and so forth. Now, all of this that you see here, kidney issues, blood pressure issues, and so on and so forth, and obviously swelling because, well, their blood vessels are dilating and they're obviously leaking, so they get puffy, very puffy. If it goes untreated, eventually those chemicals can get toxic enough And now they get into that seizure state, which is eclampsia. And that's typically where you'll probably show up in these cases, because here they're resting. They're fine. They're okay-ish. But even with proper care, this buildup can occur. And when it does, again, it can lead to that seizure occurring, and that's when we'll get probably called. So by definition, this is what it is. It's one or more generalized seizures in that patient with preeclampsia. It's just a transition phase. That's all it is. That can occur, as you can see here, from 24 hours up to about 4 weeks after the fact. So it's still one of those possibilities, even though they've given birth a long time ago. Now, how it's managed, this is a little bit more on the ALS side, so I'm going to jump through some of this real quick for you guys here. Most of it is just basic, again, seizure care, which is what? What do we do for patients that are seizing? Okay, so in this case, she's already in bed. And let's say that she's not pregnant anymore, but if she were pregnant, what side would you want her on? Put her on her left side, good. All right, so we do that. We obviously make sure she's not gonna fall and hit her head, or, run up against anything, or anything's gonna fall on her, or any of that stuff. What else do you wanna do for her? Basic care, what are you gonna do? Okay, oxygen, however she'll tolerate it. Okay, keep her warm, try to keep her calm, and again, pad up around her if you can, just to prevent any kind of trauma. And that's about it. Sometimes the seizure will stop itself. Sometimes it's going to take medics to come in and do it. If they do, usually again with the first line drug, they're going to give us some type of a beta blocker. They're going to try to slow the process down. Especially in this case, they're going to try to drop their blood pressure, because that usually is one of the bigger keys. They spike their pressure so high, and that's causing that irritation in the brain. So if that doesn't work, right, and doesn't resolve, eventually they'll go to other medications like Versed. They'll go to mag sulfate, things like that. Here's the problem with mag sulfate also, which you will also have to watch for. As I told you, mag sulfate is a smooth muscle relaxant, which again would relieve the blood pressure problems here. The bigger problem though, because we're given so much of this stuff, I mean, we're given 4 to 6 grams of this. I mean, we're just boatloading them full of this medicine, is that there's a very high possibility that either A, that blood pressure may drop too far, which we may have to manage a little bit as far as volume issues, but even worse is that it can cause a very severe amount of respiratory depression, to the point where they could go into respiratory arrest just by getting this medication. So if that happens, what y'all gonna do? And don't say call 911. That's exactly. Put in a basic adjunct, ventilate them. Eventually this will wear off, and or your medics do have the antidote for this, so they can give a little bit of it if they need to. And the antidote, by the way, is calcium. So that may have to be managed on a case-by-case basis. If it gets to that extreme where they stop breathing or they're not ventilating very well, then fine, ventilate for them. That's it. But you got to get that seizure stopped, because that's the worst of all the things that are going on in this case. Okay, so here's the last thing we're going to talk about. As I said, this is out of all the possibilities that you see with possible problems postpartum. I'll say that fast 5 times, right? Is what's called this cardiomyopathy secondary to being pregnant. As I said, when a patient goes full term, okay, her blood volume, let's say, is normally 5 liters. At the time of birth, she can have in upwards of 8 to 9 liters that's circulating, because she's obviously got to circulate in the large uterus, the baby, and herself, right? Now, that volume just doesn't magically disappear, and magically doesn't have any consequences. The problem is that you're going to have, over a period of time, especially in those later trimesters, a significant amount of volume coming back to that right side of the heart. All right, and as long as it's perfusing, right, it won't cause too many problems, but it still can cause deficits in patients that are pregnant, and that's what we see right here. So typically, where, like I say, we see this on average somewhere between the last month of pregnancy or the first 5 months after they've given birth. The other thing is that they typically, usually just about every time, do not have any history of heart problems prior to pregnancy. So this is a brand new thing. They do have heart failure now. Okay? They didn't have it then. And the third thing is they get measured. This is usually going to be in hospital or by their OB or somebody. Their ejection fraction, which is on the left side, is compromised. It's less than half of what it should be. That's the criteria that puts them into being diagnosed with this. Now, obviously what's going to lead to this is obviously being pregnant, which we talked about, but high number of kids having a history of either being diabetic or again being overweight. If she's had multiples, so she's got twins, triplets, quadruplets, octuplets, okay, whatever the case may be. And again, the high risk factors, 30, 35 years old. We'll go past that. So here's what's going on, and a couple of different things, and I'm just going to kind of give you the highlights of this. The first thing is that it's that return. Okay? It's the return of that volume that's in high volume compared to what's normal. And with that, the left side especially now has to compromise for that. The left side has to take that volume and it's got to push it because it's coming through, right? As it does so, it can actually cause a stretch not only on the right side, but also the left side. And as that left side especially starts to fail, that's when these patients really start to become symptomatic. And we start to do, in this case, see pulmonary edema. We start seeing signs of basically CHF, secondary to that overstretching of the heart, secondary to all this volume that's been retained and not been processed over that period of time. The other thing is that sometimes it may be related to, again, an immune response. They're still not sure exactly how that works, but it's very somewhat similar to what we saw with that amniotic fluid embolism, but not quite as severe. If there's issues with their nutrition, especially if they're low with iron and selenium, that tends to be a factor. They don't know why still, but that is very common in a lot of these patients. And or this. Now, I will tell you that between 2019 and 2021, there was a significant spike in diagnosed cases of this cardiomyopathy. Why in that time period do you think that's the case? What caused it? Well, what was going on during then? COVID. And just like with kids that were developing, these multiples, of kids that were developing myocarditis, which is a very rare thing to happen, it was happening in these females as well. And they think it was attributed to that COVID infection. They think. But again, there's lots of other reasons why this can happen. Typically what's going to happen is that you're going to see this picture on the right here eventually develop. Excessive fluid, lack of ability to compromise for it, and once both sides start to fail, their heart looks like this. Right? It is a very inefficient pump at this point. And so fluid doesn't move forward, it moves backwards. And like I said, now we have lung involvement, we have organs aren't being perfused correctly, all kinds of things like that. So that being said, again, the various signs and symptoms here are very similar to CHF, like I talked about earlier. A little bit of JVD while they're sitting up. You might start to see, again, some enlargement of the liver because it backs up in the venous system down here. They start to swell up and get the cankles and so on and so forth. Or they have that full body type of fluid retention, which we call ascites. You may hear, if you're listening to heart sounds, you might hear some skipping in there because, again, the inefficiency of the heart as a pump and or some other clicks or murmurs as well because of the fluid now messing with the valves and causing them to stretch and obviously become inefficient as on top of that. So they're kind of a hot mess, really. All right, and you get a heart like this, not many people can survive with that. So what does tend to happen in a lot of cases, it happened in none of the cases, those gals I told you, all 5 of them, none of them ever got to this extreme as far as what I'm going to tell you now. They did have signs and symptoms like this. They all agreed that they did get some very severe signs of CHF. But what's going to have to be done, and we'll kind of skip past this right here because that's more ALS, is they either A, are going to buy themselves a pacemaker, but more than likely, these might be the patients in their early 30s that end up with a ventricular assist device. Because the ventricles are shot. They're so stretched out they can't contract. It's either they get a heart transplant or they get the machine, or they die. So you choose, okay? And in some cases, the damage is so extreme that they may be able to be a candidate for a new heart, or again, because of certain other parameters, they may not be a candidate, and they're going to be basically stuck on this ventricular assist device for the rest of their life. And that's the very extreme possibility, but it can and does happen in some cases. So There we go. So as I said, that's a little bit of some taste of what can happen after birth, and what can happen with these patients. The biggest thing, like I said, you're going to really worry about is going to be those bleeding issues, probably also the pulmonary embolism and respiratory issues in a lot of cases. But again, preeclampsia does happen as well as these rare instances with anaphylactic reactions as well as enlarged hearts. So if you want this presentation and or any others that you saw this weekend, you go to that QR code. Like I said, it's going to take you right to my website. All you got to do is just find the menu, look for the contact page. You have all the information there. I'll give it whatever you want, and you're more than welcome to it. So, could I write it down? I can write it down for you. I can give that to you before I leave. Okay? All right. So that's all I have, folks. Thanks very much.